I would like to thank the organizing committee for the kind invitation to be part of this Congress and present our laboratory, our cath lab work. Even if we are three interventional cardiologists trained to perform TAVI, due to the legislation rules and restrictions in our country, we do not do TAVI, but we are doing all the other structural interventions. So I warn you, this is not a TAVI case. A hole in the heart, a silent killer. This is the case of a 57-year-old male, diabetic, hypertensive with obesity and COPD, current smoker, with a recent hospitalization due to respiratory infection, which put him 1 month in bed. He was admitted to us due to crushing chest pain with normal hemodynamics, maybe some reduction in the saturation, oxygen saturation. And this is the presentation ECG. As you can see, there is an RBBB with an ST elevation and the arterial leads. The patient was transferred to the cath lab, and the emergency coronary angiography revealed an abrupt closure of the proximal left anterior descending, and followed the primary PCI. As you can see, there is a large thrombus burden, high thrombus burden in the LAD, but with a very nice result after the primary PCI. The patient was transferred to the coronary care unit under aspirin and ticagrelor and tirofiban IV for 12 hours due to the high thrombus burden. This is the post-PCI ECG. There is no RBBB and the evolution of the anterior STEMI. Our fellow that it was in charge of the patient in the coronary care unit noticed that the transthoracic echocardiography, this floating maze, that it was expanding from the atrial septum, and as you can see at the image on the right, maybe it was something also at the right atrium. So, and also it was an dilated right ventricle. Due to these findings at the right and left cavities, we decided to proceed to transesophageal echocardiography. The patient remained under anticoagulation, and the autoimmune nephrophilia screen was conducted, which showed no evidence of hypercoagulability. The blood gas measurement under mask ventilation with oxygen at 21% showed hypocapnia and hypoxygonemia. Everybody is thinking the same thing. And this was the impressive image of the transesophageal echocardiography with this large floating thrombus through a patent foramen oval. And also there were floating thrombus in all heart cavities. The following CTPA revealed the pulmonary embolism of both major pulmonary artery branches with RV thrombus also. According to the simplified pulmonary emboli severity index, this was an intermediate to high risk patient, and according to the guidelines, the best therapy that it is indicated was a catheter-directed percutaneous treatment for this patient, and these are the studies that justifies that this option is safe and also efficient. Also, the FLAIR study, which included 106 patients with intermediate to risk acute pulmonary embolism, the percutaneous treatment had a statistical significant reduction of the pulmonary artery pressure, which interpreted with better results in mortality. So, in collaboration with the interventional radiologist, we proceed to the catheter-directed aspiration thrombectomy. The aspiration guide catheter, it is deployed over the wire to the interlobar artery at these images to the left interlobar artery, and also the flared trivial catheter discs are deployed to distally in segmental branches. And these are the results of the aspiration thrombectomy. Many thrombi from different morphology, something that it is indicating that probably there were several sequential episodes of pulmonary embolism. And repeat angiograms of right and left lung showed marked improvement at the flow of both lungs before and after the aspiration thrombectomy. And this is the echocardiogram 24 hours post-aspiration thrombectomy with no evidence of thrombus and better measurements from the RV cavity. So gathering them all, someone could say that it is a rare case of paradoxical embolism with STEMI due to a PFO. It was complicated with pulmonary embolism with intermediate risk, but with a large thrombus burden in right and left heart cavities. The patient was treated successfully with aspiration thrombectomy and with anticoagulation with apixaban properly. And after 1 month, she was scheduled for a PFO closure that it was successfully, as you can see at the echo images after that. Thank you very much for your patience because it is late and I'm open to discussion.
Gerasimos, very nice case, very nice case. To my knowledge, at the moment, we are doing thrombectomy in cases where there is contraindication to thrombolysis.
Yes.
Here there was a contraindication to thrombolysis, or you decided to go?
It was the real contraindication was that the patient was under DAPT, dual antiplatelet therapy, and she received the tirofiban for 12 hours. Less than 24 hours after the initial primary PCI, she deteriorated with mostly not hemodynamically. Hemodynamically, the blood pressure was about 90 to 60 with a low dose of vasospastic drugs, but mostly by reducing a lot the oxygen of the saturation less than 90%. So we didn't want to proceed with thrombolysis because we had also previous cases with not so good result and the outcome was bad for the patient, so we decided to proceed to the thrombectomy. Since we had also the interventional radiologists, they had the equipment and the expertise also for that.
You had also thrombus into the RV. There was a lot of thrombus. Maybe a systemic lysis will be better, but anyway, it was a very nice case.
I didn't mention that we also performed an ultrasound, but there was no evidence of DVT. So we thought the question here was that if it was a DVT with a paradoxical embolism that resulted in STEMI and pulmonary embolism simultaneously, or just a STEMI that it was complicated with pulmonary embolism and it was incidental finding the PFO.
Gerasimos, all this thrombus burden began from the left ventricle.
This is something that we have to discuss it. I don't know for sure. I don't know if we had to close the PFO also.
Dr.
Yes,
Gil.
Dr. Gil.
One very short comment because of the time period, but very excellent case. And this PFO also was a risky PFO since longitudinal PFO or not. Is it longitudinal PFO?
Yes, it was. Yes.
Was it long channel? For example, for the PFA closure session, I prefer to close that kind of PFO in not a regular way, maybe with transeptal puncture, because there can be even residual thrombus there, and during the passage of the PFO, there can be risk of arterial brain embolism. We know that kind of a case, so my recommendation is to do that kind of PFO with thrombus burden, to do transeptal puncture and close the PFO on atrial septal aneurysm. But congratulations for the case.
We tried that after 1 month under anticoagulation treatment, so we proceeded this way.
Congratulations. Congrats, Erasmus. Can I have a comment, please? What was the technical issue? What was the catheter that you did the aspiration? What kind of catheter? What the size of it?
I do not know exactly the details, Yannis, because it was performed by the interventional radiologists, but it was this flow trivia and the accompanying aspiration guiding catheter. But it was done through the right common femoral vein, as usually.
How was the duration of the procedure? How long was it?
It was about 30 to 45 minutes, I think.
Okay. Because I saw large thrombus,
yes.
Pieces of thrombus, really large pieces, and it was impressive. Fantastic case.
Very, very nice case. Thank you. I think there is no question in my mind that this PFO should have been closed because it proved itself. There was a large thrombus there that, no matter where it came from, it was there. So should be closed. And I think 6 weeks after very intense anticoagulation can be closed with pretty much safe.
I agree with you, but it is a debate in the literature. That's why I mentioned that. But it is the best for the patient, I think.
Okay, I think we should finish. Thank you very much.